Morning, my name is Kabeer Ali, and today I'm going to be presenting on central nervous system involvement in splenic marginal zone lymphoma. My co-authors are Jennifer Miatek, Falguni Patel, Abhinav Karan, and Walter Kwan. Marginal zone B-cell lymphoma represents a heterogeneous group of indolent non-Hodgkin lymphomas originating from the marginal zone of B cells in lymphoid tissue. We present a case of a patient with a ventriculoperitoneal shunt and recently diagnosed splenic marginal zone lymphoma who presented with status epilepticus and was subsequently diagnosed with secondary CNS involvement. A 49-year-old male with a past medical history of recently diagnosed splenic marginal zone lymphoma, seizure disorder, and hydrocephalus with a ventriculoperitoneal shunt presented with status epilepticus refractory to anti-epileptics. He was recently diagnosed with extranodal marginal zone lymphoma with bone marrow involvement as an outpatient. CT abdomen and pelvis showed significant splenomegaly measuring 20.7 centimeters in craniocaudal dimension with an ill-defined hypodensity in the dome of the spleen, as shown in Figure 1. Peripheral flow cytometry showed mature B-cell lymphoma involving 68% of live cells. Peripheral blood smear showed evidence of villous lymphocytes. This is shown in Figure 2. Bone marrow evaluation confirmed mature B-cell lymphoma, which was CD20 positive, involving 70% of marrow cells. There was no overt increase in myeloblasts or plasma cells. An MRI brain without contrast revealed no acute changes, but stable chronic lateral ventricle dilatation and ventricular shunt placement. This is shown in Figure 3. A lumbar puncture revealed a glucose of 63 milligrams per deciliter and protein of 38 milligrams per deciliter. Cytology was significant for rare lymphocytes. Flow cytometry of the CSF revealed 3% monoclonal B cells, concerning for lymphoma involvement. The sample was clear, and no red blood cells were identified in the CSF sample, which would indicate possible contamination. He received intrathecal methotrexate and hydrocortisone. Subsequently, after intrathecal treatment, the patient demonstrated no further seizure activity. The patient returned to baseline mentation and functional status. Repeat lumbar puncture after intrathecal treatment revealed no further malignant cells. The patient was subsequently discharged with an outpatient treatment plan with rituximab 375 milligrams per meter squared for 4 doses. Figure 1 is a patient's CT abdomen pelvis, which shows significant splenomegaly, and the red arrow highlights the hypodense lesion in the patient's spleen. Figure 2 is the patient's peripheral blood smear on admission, highlighting a villous lymphocyte. Figure 3 is the patient's MRI brain. This image is shown in FLAIR sequence and shows stable ventricular dilatation and no evidence of leptomeningeal enhancement. Marginal zone lymphoma comprises only 5 to 17% of non-Hodgkin's lymphoma. CNS involvement in marginal zone lymphoma is uncommon and occurs in approximately 1 to 2% of cases. Despite its rarity, the incidence may be underestimated because it is asymptomatic or underrecognized. Diagnosing CNS involvement in marginal zone lymphoma relies on clinical assessment, neuroimaging studies, cerebrospinal fluid analysis, and histopathological examination. Imaging findings may reveal leptomeningeal enhancement, parenchymal lesions, or both. Cerebrospinal fluid analysis may demonstrate lymphocytic pleocytosis, elevated protein levels, and the presence of atypical lymphoid cells. In our case, the diagnosis was supported by monoclonal B cells within the cerebrospinal fluid. Limited data is available regarding secondary CNS marginal zone lymphoma, particularly concerning the efficacy of CSF analysis for its detection. So in conclusion, due to the rarity of CNS involvement in splenic marginal zone lymphoma, it is imperative to report such cases, as there are currently no standardized guidelines on diagnosis or treatment. Thank you very much.